Hi, and welcome to Exploring Asian American and Native Hawaiian Pacific Islander Identity and Health Equity. My name is Erica Burrows Girardi, and I'm a Senior Outreach Specialist with County Health Rankings and Roadmaps. I have a quick disclosure I need to share with you right away. I live in Florida, and right now we're having some internet issues, and I want to let you know that there is a slight possibility that I will be bumped off the webinar, but don't worry, you're in good hands. And should that happen, Joanne Lee, who is the associate producer for this webinar, will definitely lead in facilitation. So with that, I want to let you know that this is the third webinar in a series that we have been producing called Advancing Racial Equity. And Selma is going to chat a link to the series description, in which you can then get another link to watch the first two webinars in this series on demand. Now, I've told you about Joanne and Selma. I want to introduce you to them because they are going to be helping facilitate your learning experience. I will start with Selma. Selma is a community coach, and she is the co-producer with the organization or with the program that is helping to produce this series. It's called Mobilizing Action Toward Community Health. Hi, Selma.
Hey, Erica, thank you so much for allowing us to co-produce as well as welcome everyone to the webinar. My name is Selma, and I will be engaging with you in the chat box today. Feel free to interact with me and other folks there. However, just a reminder that questions you have for our speakers can be put in the Q&A box where Joanne Lee with Healthy Places by Design will meet you there to connect. Hey, Joanne.
Hi, Selma. Hi, everyone. So glad to be here. Joanne Lee with Healthy Places by Design. We have been a longtime partner with County Health Rankings and Roadmaps in producing these webinars and post-webinar discussion groups, which I hope many of you will join. Before we move on, I have to introduce our behind-the-scenes magician, James Lloyd. He is our technologist who does so much magic to ensure that these webinars go smoothly. Hi, James.
Hi, Joanne. Thank you so much. I'm so honored to be able to participate in this really worthwhile discussion today. I work with County Health Rankings and Roadmaps as the technology coordinator. And if you have any questions regarding technology, you can pass them into the chat to all panelists, and I'll keep an eye out there for those questions. And also here to support our wonderful presentation staff. So with that, I'll turn it back to you, Erica.
Thank you so much, James. And I'm excited to introduce you to our amazing guests who will be joining us today. I want to start with Dr. Simona Kwan. Dr. Kwan is the director of the NYU Center for the Study of Asian American Health at NYU Grossman School of Medicine. Hi, Dr. Kwan.
Hi, everyone. Thank you for the invitation, and I'm really looking forward to the conversation.
Well, thank you so much for joining us today. And also, please join me in welcoming Dr. Nia Aita-Oto, who is an associate professor at the University of Utah's College of Health and an adjunct associate professor at the John A. Burns School of Medicine at the University of Hawaii in Manoa. Aloha, Dr. Aita-Oto.
Aloha, and thank you for allowing me to be in this space.
Good, good. We're going to ask you to speak up a little bit later when we bring you back into the conversation, because I want to make sure that folks can hear you. Now, you can learn more about our guests' amazing biographies on a bio sheet that we're going to post online tomorrow, along with your resource guide. So I want to share some of the goals that we have for today's webinar. By the end of our time together, we hope to have answered these three important questions. What stereotypes and past racist policies continue to hurt Asian Americans, Native Hawaiians, and Pacific Islanders today? And how is using a single Asian American or Native Hawaiian Pacific Islander category in decision-making and data collection masking health disparities? And most importantly, what steps can we take to support Asian Americans, Native Hawaiians, and Pacific Islander community members in advancing racial health equity? I know that there are some of you who are very familiar with county health rankings and roadmaps, but we do have some new folks in the audience joining us today, and I want to take a moment to tell you a bit about us. County Health Rankings and Roadmaps is located in the University of Wisconsin Population Health Institute. We have several partners across the nation, including the Robert Wood Johnson Foundation. We are very committed to improving health outcomes for everyone. Evidence shows, however, that we cannot improve health outcomes for all without a commitment to equity. Therefore, we're very much committed to advancing equity because everyone has a right to thrive, no matter their zip code, the color of their skin, age, or any other aspect that makes us unique. So to do this, to help with these two goals, we provide data, evidence, guidance, and stories to help you create change. Now, for more information about our work, I want to encourage you to watch the 2021 CHRNO 101 webinar. A link to that webinar will be included in your resource guide. And now I want to invite Selma back to the mic. She's going to tell you a little bit about mobilizing action toward community health, which we call MATCH.
Thanks, Erica. As you just mentioned, MATCH stands for the Mobilizing Action Towards Community Health, and our research and work focuses on equity, collective community action, health in all policies, power building, and organizational policy and systems change. Through a field building approach, MATCH works with partners to evolve practice, focus priorities, and shift power to enhance collective action on root causes of health and equity through 3 strategic strategies that you see right on that screen. So training, alignment, and engaged research and development.
Thank you so much, Selma. Match has been the perfect partner in this Advancing Racial Equity series, and I want to sincerely thank you and your program for your contribution to the series. I'm very excited about the content we're going to be hearing today because for me, a lot of it was new. I have been a public health professional for 26 years, and I have learned so much from our 2 guests about public health that I didn't even learn in school. So chances are you may be like me and you will need to think about how you can unpack some of the things that you're going to learn today. I'm pleased to tell you that we're going to have an opportunity to do just that. We're going to hold an interactive discussion group to deepen your learning after today's webinar. Some of you have been a part of these conversations in the past. You know that they give you a chance to be with other webinar participants and to share what you are doing locally is ask questions of other participants. So we're pleased to be able to offer these sessions in partnership with Healthy Places by Design. Joanne will be our lead facilitator, and Drs. Kwan and Aita Oto will also be joining us today. Watch the chat for details about how you can connect later because Selma will be chatting out the information about that. Now I want to shift our conversation to the reason behind this series, and that's racism and how it obstructs health. Here at County Health Ranking, here you see rather the County Health Rankings model, which displays multiple factors that influence health. And you'll notice that there are 4 buckets in which we organize these multiple factors. Both the American Public Health Association and the Centers for Disease Control have identified racism as a public health threat. Now you might be wondering, how is racism associated with health factors? You need to know that racism limits opportunity to health in all 4 buckets. In fact, research shows that racism is so embedded in our norms, practices, and policies that people experiencing racism struggle to reach their optimal health within these 4 factor buckets. And that's why this series has been so important to us. The good news is we have the power to change this. And that is the reason why, again, this series has been important to us. And we want to be able to share and strategize together with you about how we can fix the issue of racism obstructing health. Just before we hear from our amazing guests, I want to make an important point about cultural identity and historical context. Both are key if equity is going to be the outcome, because you simply can't achieve equity for any population without understanding these key components. By cultural identity, I mean an individual's identity as a member of a group with shared characteristics. Examples can include race, ethnicity, geographic origin, age or generation like baby boomers, or gender, she, he, or they, how we identify ourselves. It's important to note that cultural identities can be chosen. Like, I choose to define myself as a Southerner, although I spent the first 6 years of my life in the Northeast. However, cultural identities can also be assigned by policy. It could be a social construct, and we often see racial identities assigned. We all embody multiple cultural identities. Again, I'm a Southerner, but I also identify as an African American cisgender woman. Equally important is historical context. Like, how do we get here? Health inequities didn't happen on their own. They are the result of historical policies that created an environment where some populations thrived and others do not. So a population's group identity and historical context is so important because it can influence decision like access to healthcare, like if implicit bias or racism is involved. It can influence how we perceive the validity of health information we receive or hear. And it can influence how we engage with healthcare providers. Um, do they share the same cultural norms? Do those meanings have the same thing for us? It can also determine whether or not we trust our healthcare provider or system. So what we're going to learn today is that assigned cultural identities and the historical context of Asian American, Native Hawaiians, and Pacific Islander residents have had an impact on their health. I want to begin to unravel these issues with welcoming back Dr. Simona Kwan. Dr. Kwan, let's start by defining this AAPI category. Like, how did this category grouping come about? And who does it include?
First, I want to start by sharing that Asian Americans are the fastest growing population, and they're expected to grow to 39 million by 2060. They represent nearly 10% of the US population, and in New York City, where I'm based, they already represent 15% of the population. And the composition of Asian Americans has changed over the past century, becoming more diverse with respect to national origin. So in the early 20th century, the Asian American population was primarily made up of Chinese and Japanese Americans, which served to define Asians in the US as East Asians. Today, East Asians are less than 1/3 of the population, but Asian Americans continued to be defined as only or limited to East Asian populations. The 2016 National Asian American Survey found that more than 40% of white Americans believe that Asian Indians and Pakistanis are not likely to be Asian or Asian Americans. But this is true even among Asian American groups. 27% of Asians similarly believe that Pakistanis and 15% believe Asian Indians are not likely to be Asian or Asian American. So this is one recent example. In the 2020 presidential race, during his run, Andrew Yang, who is of Taiwanese descent, was frequently framed by the media and his own campaign as the Asian candidate, really minimizing Kamala Harris's Asian Indian heritage. And so the media and general US population often excludes and does not perceive South Asians as part of the Asian American group.
Yeah, and this is part of this cultural identity and the assignment of these identities. And so we see how complex this can be. Now, I know you all can't see this slide. It's okay. We're going to go through what it's saying, but you can get a copy of the slides from the link that Selma chatted out earlier. So Dr. Kwan, tell us a little bit about what this slide is telling us.
Basically, this is a graphic created by the Census Bureau, and essentially race and ethnicity are social constructs. And often the groupings that we use do not reflect how people identify, label, or categorize themselves. So this is really an evolution of the race ethnicity census categories over time, underscoring that, again, these groupings are really made up and influenced by political attitudes, advocacy, and immigration patterns.
And you can just see just how much they have changed over the course of a couple of centuries. And what changes have we seen in the population over the last decade, though?
Today, Asian American population is increasingly diverse and again represents three broad subgroups: the East Asian, Southeast Asian, and South Asian communities. And again, you can see that the East Asian population is less than 1/3 of all Asian American groupings. I also want to note on this graphic, this is an NPR graphic that includes at the bottom Native Hawaiian and Pacific Islanders, and the graphic title is Under the Asian American Umbrella. And I really defer to Dr. Aita Oto and her leadership and deep experience to unpack the concerns related to the use of these type blanket or umbrella terms. And I'll be focusing primarily on talking about the Asian American population, so as not to contribute to the aggregation and erasure of the distinct context and experience of Native Hawaiian Pacific Islander communities.
Yeah, I appreciate that. Let's talk about where we see the geographic distribution of Asian Americans today.
So this map shows where the Asian American population resides in the US, and they're really spread across the whole country. More than half though do reside in 4 regions: California, New York, New Jersey area, Texas, and Washington. But you can see that there are large pockets across the Midwest and the South.
Yeah, I live in Florida, and we see that there's a growing population here in Central Florida, which is where I'm located. I want to get into this issue of stereotypes, because these stereotypes, these narratives that we have heard is actually is what's rooted in some of the racism that we see today against Asian Americans. So let's start with, I know you're going to give us sort of like a little perspective of the stereotypes that have permeated AAPI community and that has given rise to racist policies and practices. Let's start with what we see here.
Yeah, so the graphic on the left is about the 1882 Chinese Exclusion Act. And this was the first piece of US legislation that barred a specific ethnic group from immigration and naturalization. So this specific cartoon is from 1879, and it depicts the racialized position of both Blacks and Chinese in this period. And these perceptions really didn't change until 1965, when the quotas for Asian immigrants were increased. So this was the 1965 Immigration Act. And you can see in the figure that the act increased overall country quotas. And you can see the big bump up in immigration. And there were 2 specific components of this act. It provided selective preference for immigration for family members, so the reunification of families. And the second one is a selective preference for professional level immigrants to fill workforce gaps in the US. And this last preference significantly shaped the immigrants from Asia and really helped to undergird the model minority stereotype, which was and is so pervasive, it effectively erased and reframed the earlier racism and discrimination against Chinese and other Asian American groups from the previous 100 years.
Yeah, and this is the one that a lot of people are familiar with now. So that stereotype, let's talk about it.
So the model minority stereotype paints Asian Americans as a monolithic community, categorized as passive, compliant, hardworking, and have overcome all barriers and have succeeded professionally and economically. But we know that this is an artificial construct. It was developed by the white conservative majority to oppose the Black Power movement of the 1960s. So by touting the perceived collective success of Asian Americans, this stereotype was constructed to prove that the US society is fair and equitable, and that you can achieve success if you just work harder. And it was deployed by the conservative majority to deny the existence of systemic or structural racism in the US.
Yeah, that pull yourself up out of bootstraps, Montavo. And then we saw what happened during World War II, and that also had an influence in how we think about Asian Americans today.
Yeah, so another stereotype or perception about Asian Americans is that they're a perpetual foreigner. Asian Americans are not seen as real Americans. And during periods of hardship or conflict, we've historically and currently have seen Asian Americans being questioned about their citizenship. And the first example is about the presidential executive order that was signed and issued during World War II in 1942 that led to the mass internment of over 100,000 Japanese Americans. And the top photo is of a Japanese-owned grocery store in Oakland, and the photo was taken in March of 1942, so 1 month after this executive order was issued. And the US-born owner was later relocated to an internment camp in Arizona.
And some of you in the audience may remember a candidate in Ohio named Lee Wong, who made a dramatic statement by taking off his shirt at a city council meeting to challenge the stereotype that Asians are foreigners and therefore cannot be patriotic. And this showed that the perpetual foreigner stereotype is very much alive. I mean, this began in the 40s and we're talking about 2021. So if you haven't seen that clip, by the way, we actually included a clip of that, of him taking off his shirt and challenging that stereotype in your resource guide, because it was very impactful, very, very dramatic. And it just shows the depth of that stereotype is really built into a narrative that we carry with us in the United States. And now we're seeing Asian Americans as targets of violence since the pandemic. According to a report from the Center for the Study of Hate and Extremism, hate crime reported to police in 15 of America's largest cities and counties rose 169% in just the first quarter of 2021 compared with that same quarter of 2020. So I want to remind the audience that violence is a public health issue. Dr. Kwan, what recommendations can you give us to build social solidarity with our Asian American brothers and sisters?
Thank you, Erica. There are resources for reporting and documenting these anti-Asian events. Much of it has been crowdsourced and created by Asian American community activists due to the lack of response or coordinated tracking by governmental agencies. So one portal is the Stop AAPI Hate online portal, which has been created by a coalition of grassroots advocates. In addition, many local and national groups have created bystander training materials or safety materials, and included in that is the Asian American Federation, which has a whole suite of trainings and toolkits. But I agree, but there absolutely needs to be a strong movement towards solidarity and coalition building to foster a collective anti-racism movement that's inclusive of and works across BIPOC communities, while paying attention to the unique context and historical and systemic trauma experienced by the different groups. So we need to work together to decenter those who benefit and continue to benefit from the maintenance of the status quo.
Right. In fact, we're going to dig into that right now with the next slide. But I also want to let you all know that we are going to include on your resource guide some of those resources about how you can intervene and become part of more of a social solidarity movement, but also how you can report hate crimes as you see them. So you can have some support in that. Yeah, I want to talk about this tension that, quite frankly, I've experienced as a Black American, and what I've witnessed with some Asian Americans. So there's this tension here that I am learning, just didn't come about naturally. And I want you to share that with the audience.
Yeah, so I like to use this figure. This was a 1999 figure that a sociologist, Claire Jean Kim, created. And it's called the racial triangulation model. And it really illustrates the politicized and racialized role Asian Americans have been placed in by the conservative majority and how it's rooted in anti-Blackness. So it's an artificial and strategic position that's been created for Asian Americans and used to reinforce Asian Black tensions and to uphold white privilege racial hierarchy. So this depicts how Asian Americans have really been used as a racial wedge between whites and Blacks. And so what you'll see is on the y-axis going up, Asian Americans are labeled as being superior to Blacks. So the model minority stereotype, but inferior to whites. And then on the x-axis along the bottom, Asian Americans are labeled as outsiders, so that perpetual foreigner stereotype, while the whites and Blacks are both insiders. So this perpetual foreigner stereotype is illustrative of what happened to Vincent Chin in Detroit in the 1980s, and during COVID, what we're seeing with the increase of anti-Asian hate and violence.
Right. And once again, just pulling that social solidarity, like you were saying, of BIPOC groups needs to come about in order to contradict that, basically, that wedge. This, some of you in the audience may recognize this report from 1985. Dr. Kwan, tell us the significance of the Heckler Report and why it was still lacking when it came to describing Asian Americans, because this is a monumental report.
Yes, yeah, the Heckler Report is a turning point and significant in its impact in advancing awareness and attention to minority health. And while the report is a historic step towards improving the health of communities of color, it contained limited information on Asian Americans, and the data that was presented in the aggregate showed that Asian Americans were healthier than all other groups, which directly aligns with the model minority stereotype and perceived biases. And this report has really shaped the narrative in public health on discussions about Asian American health and health disparities to this day.
And we see how that plays out with data and how data is collected or even reported.
That's correct. So health-related research programs and practices for Asian Americans is really sparse. Despite federal legislation and initiatives prioritizing data disaggregation and the advancing of health disparities research, 0.17% of the overall NIH budget has been allocated to Asian American and Native Hawaiian Pacific Islander related clinical research projects over the past 2 decades. And this has really resulted in a lack of Asian American data research. It impedes health planning and the development of evidence-based programs, strategies, and resources.
Yeah. Tell us what happened with the Affordable Care Act.
Yeah, so this is just one example underscoring how Asian Americans are systematically excluded from the discussion. So this is a report in AJPH. There was significant Asian American data that was available for inclusion in this analysis, but per the authors, and this is a direct quote from the manuscript, we focused on non-Hispanic whites, non-Hispanic Blacks, and Hispanics in line with much of the literature on health disparities. So health systems, research, and policymakers continue to systematically perpetuate and reinforce stereotypes that Asian Americans are doing better than other groups, and so completely excluding them in the discussions on health disparities.
Yeah. Folks, if you haven't figured it out, we can't achieve equity this way. Things have to change. Let's go through a couple of examples of where we see some data gaps or masking, if you will. Let's start with education.
When you look at the education attainment levels in the aggregate, you see higher levels for Asian Americans compared to all Americans, so 30% to 20%. And these findings are really consistent, again, with the model minority stereotype. And so researchers and policymakers don't perceive any need to look any further into the data. But when we disaggregate out the data, you can see that there are major differences between Asian subgroups. Several groups fall well below the 20% attainment level for bachelor's degree for all Americans, including the Laotian and Bhutanese populations. And we see something similar when we look at income. So in the aggregate, it looks like Asian Americans are doing really, really well compared to all Americans. But we're seeing stark differences again when we look by subgroups with much lower groups at the much lower level underneath the average income for all Americans.
Yeah, I appreciate seeing this because I mean, I'm just gonna lay it out there. The stereotype is that Asians are smart and that they all make a lot of money. I mean, that's what that stereotype is. But as you can see, when you disaggregate, it's simply just not telling the whole story.
I also want to use the example of COVID. During the spring and summer 2020, the data that was presented by the CDC really shaped the narrative around how we were talking about COVID. COVID-19 had highlighted deep structural inequities for racial ethnic minority communities, and Black and Latinx AO communities experienced a devastating toll. But the data continued to leave out Asian Americans from the narrative. This figure on the right, on the left, the first figure was released mid-September 2020, and it shows that Black, Hispanic, and Asian patients had significantly higher rates of hospitalization, death, and positive tests compared to their white counterparts. But Asian Americans continue to be omitted from the general reporting on COVID, largely because the narrative was set back in the summer and because in a lot of ways, these new findings ran counter to the model minority stereotype. And so on the right side, we actually looked at our data in New York City of the largest public hospital system. And what we found was, we were able to disaggregate out South Asians, Chinese, and other Asians represented by the green bars. And we found higher infection and hospitalization rates among South Asians, which was second only to the Hispanic Latinx community in gold for positive tests, and second to Blacks in red in the middle for hospitalization. But when you look at the last set of bars, Chinese patients had the highest mortality rate compared to all the other groups.
Yeah. So a completely different story than what we initially looked at if without that disaggregation. So, I mean, the take home message, folks, I know that disaggregated data is not always available. Certainly here at County Health Rankings and Roadmaps, we do the best we can. We do rank across counties and we don't disaggregate as on a granular level like we can. I mean, like we just don't have it. We don't have that data available, but I want to encourage you where you can to disaggregate and reach out to us so we can help connect you to sources where you can get disaggregated data. I want to talk before we let you go, Dr. Kwan. I want to talk about how this is played out in policy, because we know that our policy decisions are often based on data.
So these exclusions that of omitting Asian Americans from looking at the whole picture, especially around COVID, has been replicated in funding resources and policies. And so NIH's RADx Up is a $200 million program funded through congressional appropriations, and it focused on underserved high-risk populations, but it underfunded COVID-19 testing, outreach, and engagement to Asian communities in relation to their COVID risk. And Asian Americans were completely left out of the draft National Academies of Science a framework report on COVID-19 vaccine allocations, despite heavy advocacy by us and our colleagues. The final published report did include Native Hawaiians and Pacific Islanders, and it included the phrase "and other communities."
So we see that these stereotypes are continuing to be perpetuated even through funding allocations. And again, like I tell folks, we have the power to change this. So Dr. Kwan, I appreciate you lifting up the challenges. So we know what challenge we need to overcome. I appreciate that. We're going to circle back to you and when we have during our Q&A period. So thank you so much. But right now, I want to ask Dr. Nia Aitaoto to join me back at the mic. I have some questions for you.
Great. Can you hear me? I've been having issue with my volume. Can you hear me?
Okay, I can. So thank you so much. I want to start by defining Native Hawaiian Pacific Islander category. And I'm going to ask you the same question I asked Dr. Kwan. How did this category come about and who does it include?
Okay, so in 1976, Native Hawaiian Pacific Islanders were under this very broad racial category of Asian Pacific Islander. And 21 years later, in 1997, the OMB 15 directive separated Asian and Native Hawaiian Pacific Islanders. So this racial group, NHPI, are indigenous people of the Pacific Ocean. So we have the Polynesian Triangle from Hawaii down to Aotearoa, New Zealand, to Pitcairn and Rapa Nui in that area. And then on the west side, we have Micronesia from Republic of Palau to the Marshall Islands with Guam in there too. And then towards the south, we have Melanesia. So in the US, anyone that has this label of NHPI are people from the Pacific Ocean.
Thank you for clarifying that. And why is it important to separate Asian from Native Hawaiian and Pacific Islander?
Yes. So for Native Hawaiian Pacific Islander, we do have a special, narrative or relationship, political relationship with the United States, and also we have a strong history of colonization. So within the ocean, we do have a U.S. states and territories, right? So the state of Hawaii that we know of right now was the Kingdom of Hawaii in 1782, and it was the United States came in, and there was an overthrow in the monarchy, and the U.S. made it their territory in 1898, and then a state in 1959. So we had sovereign people, Kanaka Maoli of Hawaii, right? They were a sovereign with a narrative of colonization, and all that kind of stuff. But in 1993, we did receive an apology, a U.S. apology, but not a lot of policy change, not a lot of change in resources or anything like that came with that. So we're still struggling with that narrative of colonization. In addition to the state of Hawaii, we also have 3 colonies right here in the ocean. And those, a lot of people are like, well, we don't have colonies, right? So colonies are like self-governing territories. So we call them territories, right? Sounds better than colonies. So the territories are American Samoa from the 1900, and like the people of Hawaii, that they were self-governed with their Matai system, and the U.S. took possession in 1900, and then towards the west, the U.S. possessed, Guam, the same time as Puerto Rico out of the Spanish-American War. And then up north, we also have the Commonwealth of the Northern Mariana Islands. That island, or in a Commonwealth, they got the U.S. got possession after World War II. So we have a strong narrative of militarization right there in our ocean, right? And right now we have the military base there. We have a large number of Pacific Islanders that are in the military. But on top of the having the states and territories, we also have U.S. Compact of Free Association. So again, it's a military narrative, right? Mm-hmm. So after World War II, the U.S. took possession of the rest of the Micronesian islands. They were under the U.S. Navy from 1947, and then the Department of Interior went in and took control in 1951. And after that, the U.S. decided we need to have a different arrangement with them. Instead of making them territories, they have this Compact of Free Association with the 3 nations right now. It's the Republic of Palau, Republic of the Marshall Islands, and the Federal State of Micronesia. And in these 3 states, there was an agreement or a promise. So the promise, it's more of the agreement was on the U.S. Promise, right, to provide support, including health, all of this support to these their former territories. And then what we get to do in return, right, they have they have access to our land and ocean. A lot of it is military support. So for example, between 1946 and 1958, the US detonated 67 nuclear bombs on, in, and above the Marshall Island, right? Exiling hundreds of people, destroyed land and that. And the bomb did not just contain in that region where the Marshall Island is, all over the Pacific, waves and things like that. We also have military bases there, in Kwajalein. And then on top of that, FSM residents volunteers to serve in the US Armed Forces at approximately double the per capita wage as Americans. So this very strong, we kept our end of the support. But if you look at the what we get in return, the support from the US, so the data is lacking in the region. But in a 206 report, just health, right? Since we are in the field of health, in the US, per capita for health expenditure is 5,700, right? There. But the aid that's provided to these nations, right, in the FSM is 270, right? Big difference between 5,700 and 270. And then as a result, then we can go on to the next slide. There's a lot of migration to the US, right? Because under this agreement, right? So under this agreement, there is this, this migration to the US.
And so, that one thing I want to emphasize is that historical context. The fact that what we're seeing is Native Hawaiians, like Hawaii was acquired, if you will, as part of the United States in a different way than the Pacific Islands. And that has made a difference. That has created a difference in how, first of all, it created a difference in their health outcomes, in their access to healthcare, for one thing.
Yes. It created this difference in health outcomes and healthcare, but also looking at political, that's the part of racial, right? What is our political status, right? I always say, are you guys immigrants, migrants, what are you? And if you look at it with the explanation, the other thing is a lot of our history is not taught in school, right? A lot of residents or people in the US, right? They didn't hear about things like this. It's not taught in school. But by definition, 80% of Native Hawaiian Pacific Islanders are native to the US. You know what I mean? So if you're looking at the map and all that, and then the other 20%, majority of them are from, these Kofa nations. So even though they're a nation, but they have this agreement with the US. And we're also advocating for all our other brothers and sisters that are coming, like in Tonga from Fiji and all that. So all of that historical, context, right, affects our health today. And then so that's one of our many issues when it comes to this racial or even political categories of NHPI.
Right. And you were talking about how data is collected, how it's shared, and it's hard to, what have been the challenges with collecting data? I know you have shared some about what's going on with COVID-19. There is a dashboard that UCLA Center for Health Policy Research has created to be able to capture some of this data. But tell us about some of the challenges.
Yeah, I think one of our challenges is we're unknown. A lot of groups, they don't know who we are. I mean, we're known in areas like Hawaii, California, because we've been there for a while. But if you look at it, more and more people are moving towards mid-America, right? That middle America section, and they don't know us, that well there. And, that's been the narrative for a very long time. However, it was during COVID-19 that the counties and states officials in the health departments became aware of us. So we received a lot of phone calls, a lot of emails, and and that only happened when they disaggregated their data, right? Because the data came in and they saw, somebody actually asked me, who are Native Hawaiian Pacific Islanders? Who are they? And most of them are from that area from Iowa, Missouri, Arkansas. So a lot of, if you look at it, this unknown, right? People don't know who we are. And the other issue is small numbers, right? Our numbers are so small, people don't pay attention, right? Until we get a pandemic. So if you look at, with this, the UCLA Center of Health Policy and Research, what they did is they actually go into health departments data and pull out data for Native Hawaiians and Pacific Islander. And when that's done, this is just data from Arkansas. If you look at it, when it comes to infections and death rates, we're higher than any other ethnic group. It's a place that we do not want to be, right? So,
Right.
and all of that. But now they're aware of it, right? So I think COVID-19, what happened is that a lot more states, a lot more counties, health departments, a lot more aware of who we are, because the narrative, when we talk to our brothers and sisters and relatives in these states, what they usually say was that what they usually think we're Hispanics, right? And then we don't, we come in, they think we don't understand, English and that kind of thing. So there's a lot of that. So this unmasking of, who we are. So I think that is one of the major issues that we have.
And what are some ways that you have been able, through your work and research, have been able to find ways to be able to improve the quality of care that Pacific Islanders and Native Hawaiians receive?
Yeah, and I think, when a lot of this, when it comes to all the racial narratives, they were always saying like, well, it's so hard to take care of them. They don't value health. All of that kind of, on top of like poverty narratives and cultural narratives and things like that. But and it's very hard on the national level, right, to draw this picture. You can go into counties and state and do that, but on a national level, it's very hard. And they usually give those excuses, right? The number is so small, we cannot do that. So I brought in a very good example on how that can be done, right? So I work with the Association of Asian Pacific Health Organization, is APCHO. So they actually, what they did, and PICOPSI is actually a program of APCHO. We work very well together. What happened was like we took this national data set, the HRSA Community Health Center data set, and look at the quality of care. And if you look at it, we actually, do better than the national average, right? You're looking at Native Hawaiian Pacific Islander serving health centers, right? And we disaggregate it between NHPI Health Center and then just NHPI. So what you can do is, if you look at it, when it comes to childhood immunization, cervical cancer screening, colorectal, we actually can do good work, right? Because that's another, we could never fix them. We could never do anything good with that community. But if you look at it, if you disaggregate the data this way, this health center that are serving Native Hawaiian Pacific Islander can do a really good job. But that's just part of the story. The second part of the story is providing these enabling services, right, that are appropriate, right? We got to invest resources in there for case managers, for community health workers, for interpretation staff, eligibility assistance. So to me, it's like, it's worth that investment, right? Because a lot of time we hear in meetings and things like that, we keep on hearing about all the barriers, all the bad data and that kind of thing. But this really show, if we put in that investment into all of these service, we can do better than the national average, and things like that. So it's one of the great example that we can do this on a national level. These are national data, and it goes back and forth, because on a national level, we cannot have good data if community health centers or health departments in your county do not disaggregate your data, right? Because all of these data go up. So that's pretty much the message here, is everybody look internally to see your organization, your health department, how are you disaggregating this data, and report it so we can come up with a national narrative and a national report.
Right. And here's just another example of the power of disaggregating data. I want to leave with you telling us a little bit about this program, the diabetes program, the type 2 diabetes program, and how successful that has been, because it was culturally tailored toward Pacific Islanders.
Yes. So the good thing about this, it is a national program. It's very hard to find, compare, right, national programs, on the national level. We have a lot of great example on the local level, but it's very hard to find example on the national level. So there is a DPP, the Diabetes Prevention Program at the national level. So Pacific Islander, we came in, just 3-4 years ago and said, we want to do this program. We really want to translate all the materials in our indigenous languages. We did that. We want to tailor everything curriculum. We're going to keep the curriculum, but we want to tailor some of the food items there, the type of physical activities, where we meet at churches and that kind of thing. And they were like, okay. And then, so now we're looking at the success, but we want to go in and say that if you invest on listening to the community, right, invest on, tailoring, culturally, use community health workers as coaches versus like the certified diabetes diabetes educators and all that. Nothing wrong with that. But, with programs like this, we want to work with someone that look like us, right? And things like
Right.
that. So the success of this program, which is compared to, we do have a target. So the CDC and with the continental US, our target, for that first 2 years was, target was 500, and we enrolled 652. And mind you, this kind of is a 1-year program. It's very hard
Yeah.
to enroll, people into the program, right?
Right.
And yet we went over. We were the only program that actually has a waiting list, right? Because we currently tailor that. On top of that, completion is it's low, right? Because it's very high, in other situations. But anyway, in this program, the completion rate on a national level is 31.9%, right? So it's a 1-year program. For the culturally tailored Pacific Islander program is 78%, right?
Yeah.
Our completion
Yeah.
rate. And then if you look at concretely, look at average weight loss, right? Because in that program, they, the recommendation is that if you lose 5 to 7% of your weight, right, you decrease your risk of having type 2 diabetes, right? So on the, national program, the average weight, is 4.2%. For the culturally tailored Pacific Islander program is 7.2%, right? Beyond that 7%. So if you look at it, there is value in understanding or
Right.
prioritizing resources around culture, around language, around context. So yeah,
That makes
was
a difference. I mean, clearly made a difference.
it made
From
a difference.
31.9% to 78%. Well, thank you
Yeah.
so much, Dr. Aita Oto. And of course, she is sticking around as well. And right now, I'm going to ask James to share a poll with you. And he's going to leave this open for about 15 seconds. But quickly tell us if how your understanding of stereotypes of past racist policies continue to hurt Asian Americans, Native Americans, or Pacific Islanders. Has it changed? Has your understanding changed? We're curious. This is an anonymous poll, so we're not sharing the responses, but we're just curious to see if you feel like there's been some learning here. So, James, if you'll, let's leave that open for about 5 more seconds. We've been talking a lot about, you can go ahead and close it, James. Thank you so much, folks, for participating. We've been talking a lot about historical context and how important that is and understanding cultural identity. I want to let you know about our Equity Action Learning Guide. These are a suite of tools that you can use to begin to deepen your learning around equity and understanding historical context and identity and how all of that fits within health equity and health opportunity. So I want to let you know about that particular resource. And Joanne, do we have time? I think we have time for one question. And then I want to encourage people to bring your questions to the discussion group.
Great. Yes. And I encourage, we have 3 or 4 folks who really submitted some very insightful questions, and I've been encouraging them to bring that to this discussion group. We'll have more time there. But one question that I think both Dr. Kwan and Dr. Aita Oto can address is this question about disaggregating data. So, folks are really kind of taking this information in and recognize the need to disaggregate. What are some tips, particularly when in their community, there may be small pockets of Asian American or Native Hawaiian Pacific Islander groups? What's the first step somebody in local community can do to disaggregate the data? Or is this, in our presenter's view, the responsibility of the health department, or who can folks turn to? Do we want to start with Dr. Aita Oto?
Yes, and I think it start with a lot of the data for from COVID-19 is Pacific Islander, right? So let's start with the Native American Pacific Islander. When you go into the health or anything else, when you look at any form that's collecting your information, if Native Hawaiian Pacific Islander is not there, that's an advocacy point, right? Talk to your health department about, hey, there are Native Hawaiian Pacific Islanders here. You need to put this in, because that's how Indiana and all of those states, right? A lot of those counties in there put it in, because they were coming in and say, I'm not in this. Can you separate that out or whatever? But also with the ethnic groups, right? Because a lot of Pacific Islanders, there's Native Hawaiians, there's Samoans, and there's Tongans. If there's a put it in there, but also for the health department, right? To self-reflect, to look into all of your forms, right? To see is it disaggregated? There are the ethnic groups in there, right? And things like that too. Because if we don't collect it, we're not going to have the data. And also for you to report it like as such, because sometimes in some areas they do collect the Native and Pacific Island, the Asian data and all that kind of stuff, but they always report as other, right? So why don't you just report it? Even if the number is small, do that report. And if the number is insignificant for your report, put it there, put an asterisk, say like our number was small and all that kind, anything else, because if you do anything other than that, that's total erasure, right? You're just not doing. So and I think at every level, we are responsible for data, right? From personal level all the way up to the health department, all the way up to the national level.
I appreciate that. And Dr. Kwan, just before we get to you, I'm going to ask someone to go ahead and chat out the link to our evaluation survey. Thanks, Selma.
I just want to echo what Dr. Aitoto said. There is data there, and it's often in the other category. And sometimes it's 30% of the data is in the other category. So there's lots of strategies to go back and recategorize that data. There are, if it's electronic medical records, it's using surname matching. It's looking through the EHR notes to see if language was specified or US or foreign-born. So there's lots of rich data there, so you can go back and recategorize the data. And there's also, just want to underscore what Dr. Aitoto said about advocacy. Like, you need to go advocate for better data disaggregation. And that means also changing the system and asking for better data collection from the source. So better asking people their race ethnicity data, doing it in a culturally competent way, and being very mindful about how and why you're asking these questions.
Great, thank you so much. As I mentioned, Erica, there are a lot of other really good questions that I think would be great for the discussion group, where we'll have more time to address it. So folks, come on over. It's going to be a great discussion group.
It is, and I know Joanne's heading over there right now to open up the room. Thank you so much, Joanne. Hey, listen, you heard Dr. Aitoto talk about how important community health workers have been for helping to move health along in Native Hawaiians and Pacific Islanders. And I want to let you know that we recognize the value of community health workers as well. In fact, our August webinar is going to be focused on community health workers and their role in advancing equity. So I want to encourage you to plan to attend that webinar. You are able to go ahead and register for that right now. It is up on our website. We also have a treat for you next month. We are going to be doing a special topics webinar about what works for health. This is a wonderful tool to help you identify strategies that you can use to be able to build equity in your work. Some of you may have used what works for health. If not, this is the perfect webinar for you to attend. It's just going to be a 30-minute webinar, but it's actually going to give you, it's going to be jam-packed with information about how you can use this tool to move your work. That's going to be on August 26th. You can also register for that webinar on our website at this time. I want to let you know that there's ways that you can stay in touch with us on Facebook, Twitter. The best way to learn about our new tools and resources is to sign up for our e-newsletter. So I hope that you will do that. And right now, someone's going to let you know how you can join us today in that discussion group. So someone, if you would, go ahead and chat out the registration information. Again, these conversations allow you to be face-to-face with other webinar attendees and share what you've been doing. Someone's going to go ahead and chat that out. And I want to thank you. Some of you have been part of this series for the entire 3 webinars. And I just want to thank you for being courageous with us to really begin to uncover racism and its effect on health. I hope that from the 3 webinars in this series, you have learned some really good strategies that you can employ in your work to be a part of a movement of advancing equity. And part of that movement means getting rid of racism as a barrier to health. So thank you so much for being a part of this series. I look forward to seeing you in the discussion group. I want to thank our guests today, Dr. Kwan and Dr. Aita Oto. And as always, thank you to my wonderful production team and to all of you who do this work, hard work, every single day. We thank you for taking an hour of your time to join us. I'll see you in the discussion group.